Oh, 498. No, that's fine. We have two on box.
444. Good morning, all. The chair is running very, very late this morning, and he asked me to kind of get us moving and suggested that we go through the amendments. And I got them here by number. You know me, I'm OCD. So it seems like SB 444, the amendment number 1676 is the lowest on my list. And if there's anybody here that can talk about this, I don't need pink cards. For amendment 1676 for SB 444. I know it's not first on well, it is after 524.
So, Jared, did you put this together? Your name is on it.
Okay, just turn your mic on. You can leave it on.
What was the number on it?
SB 444, you
Yeah.
and Representative Hunt.
Yeah,
on-
so John and I talked yesterday, and I think he was gonna change it, and I obviously haven't looked at it to see if he has to change it to just cosmetics. I guess the governor reached out to him and said that that she would veto this if it isn't specified just for cosmetics, and so that's what he wanted to make that change, and I don't know if he has or hasn't. Maybe he has, but I don't see it here. But he told me he was going to take care of it yesterday.
Okay, this came out the 27th, which is
Yeah, that was yesterday, right?
yesterday, I think.
Yeah, no, I mean, and then when it came out, John called me yesterday and said he had this discussion and he wants to change this. So this, I guess, is probably something we're not going to pass. I said I'm fine with the change he wants to make, but I
Okay,
don't know if he had it done yet. So he said he was going to do it, so I didn't do it.
thank you, Representative Sullivan.
All right, so I want to get the action items because we're getting short on time and I want to make sure that we understand exactly what we need to do with this bill.
Sure.
So
Yeah.
the-
So
the-
so the goal of this is to collect the animal testing data that is happening in the state. And the way I wrote this was to have it so anybody who's using any company that's using animal testing in the state would have to file like a report every
report.
year with the governor's was it the Council for Animal Cruelty or something like that exists. And then they would create a report every year that is just an aggregation, so it wouldn't be individually identifying towards company A versus company B, so that, some of their concerns about privacy and potentially risks or safety risks for some of the people who work there, which was raised. So that was my goal, and then, so that's how I wrote this. That's what this does. And then I guess the feedback, I don't know, I should actually ask John how the governor even caught wind of it. I'm assuming he must have reached out to her. And she said that, I guess, this is all me secondhand, but she said that she would veto anything like that because she thinks it would hurt the biotech industry. And so he said, what if we just hold it to just cosmetic companies? And so he was going to try to change it to that to try to get at least a bite out of the apple to move towards getting this data collected. Because right now, we think that there's probably animal testing going on, but we don't have any data on what's actually happening. And so the goal of this amendment was to sort of collect it. And then in the future, if we have that data, we could talk about future regulations because then we would have the appropriate data to do it. So
So
Okay.
I'm sorry, a quick
Go ahead.
question. So the way I'm looking at the amendment? Thank you very much for the explanation. So the way I'm looking at this amendment is that it replaces the entire original bill, and it's limited to the data collection and reporting. So
That's
that's
correct.
all we're doing is the data collection and reporting for this
And,
bill.
and
But it didn't
aggregating
say
it.
anything about prohibiting any particular
Right.
industry.
Yeah, so the goal was just to collect the data so we would have it, so we would know what is happening in the state, and then we would know what kind of animals would be used as well. So I think at one point there was a discussion about only talking about certain animals, and I thought that was silly, so we should actually, if we're only using mice, then we're only using mice. If we're using mice, dogs, rats, animals, other animals, then we should know that. So that was the goal of this bill, is to just collect it by animal, aggregate it up, so that all the stuff, so it's just a statewide, we have 20 companies looking at or using these sorts of animals in these sorts of research.
And I think the reporting requirements start on line 22, outlining specifically what the report should include. The first report is due January 20th, 2028. And then it goes on to make sure that there's anonymity and confidentiality. And that's laid out so that no publicly released, and no information will be publicly released, but then there is a public reporting component. And then there's a compliance and accountability section, but I'm not sure.
Yeah, so yeah, and I put in some penalties so that if somebody on the commission were to release this information, they would be held accountable, because the goal is to have this be not
Totally
identifiable
anonymous.
by company. So that's why I had some of that extra language in there.
Class B felony. And then the compliance and accountability. So the commission, which is the Governor's Commission on Humane Treatment of Animals, will monitor compliance. And I'm just looking at the
Yeah, compliance and non-compliance.
which is on page 2, starts on line 33.
Yeah, I didn't want to put any penalties in there for non-compliance. I figured this was a good start. I thought the idea of putting in a penalty to something that's a new requirement to do business in the state was unnecessary. I think, just having the commission work with whatever company would be impacted to help them being compliant with it would be sufficient. And then if a lot of people are just not complying because there is no real penalty if they don't, then that could be something that gets addressed in the future or
Well,
something.
because we really want the data collection. We want it to be collaborative so that we get the
Right.
data. And it takes effect January 1st, 2027, with the first report due in January 2028. So it gives them a year
Yeah,
to pull the report together.
Right.
that makes sense.
Thank you.
Thank you. both
But I
of
think
you.
it's gonna be changed, so I don't
Yes.
think much of it will change. From talking to John, it sounded like he just wanted to change it to just cosmetic companies or something like that. So-
to report?
Yeah, that's what he wanted to change it to, so. I also said we could just pass this. If people like this, we could just pass this and the governor can veto it. I don't think it's our job to not do what we think. I mean, I thought this was good, but I'm willing to compromise if that would get something signed. But I'm open to that discussion. I'm not married to one strategy versus the other.
So the
So-
question on the table is, do we further amend this to limit the reporting to cosmetic company? I don't even know if there are any cosmetic.
Yeah, I mean, well, there's like Badger Balm. That's
about
one that
it.
comes to mind. There's gotta be others.
That wasn't my impression. My impression was there might be a possible ban on using animal testing
this-
for
this is-
cosmetics.
This
But it
is
was
not
gonna
about bans.
include-
This is just collecting info
Right.
about whether or
But
not
it was
they're.
also, it's also including higher.
It's just
This is a
of
replace all, though.
universities.
It is just
Yeah, that's
This is
they
a
reporting.
included
replacement.
I
too.
know, I
It
talked to John
doesn't
about
say anything about
I
any
know.
particular entity.
Right.
But if we
I know.
want to
Are you saying John
refine the
said something about a ban?
report,
Well, I'm saying that, well, I'll reserve my
Okay, so when I
information.
talked to John yesterday, he didn't mention anything about banning it, but maybe I misunderstood him. I thought it sounded like he wanted to amend this to just say disclosure.
And,
start.
and include
Yes.
higher levels, universities and colleges.
He has said repeatedly that he wants to find out what's really going on here
No, I
before he
underst-
starts banning anything.
I
So
underst-
this is your bill. This is the way it.
Right,
what
so
you
this
wrote
is,
what he
this is
said.
what so I guess the question for the committee is, do we like this? And which is all that does, it just collects the data
Right.
and will eventually create a report, knowing that the governor may or may not veto it, or do we want to amend it? I mean, I'm fine passing this,
Jer-
I mean, I think this is the way it probably should be. but-
Jared, I
just
guess I
collect
don't
the
understand
data.
what the controversy
Yeah.
would be for the,
That's it,
the
just collect
tech
the
companies or
data.
the pharma companies if it's aggregate
Fill
data
that first.
and they're not identified. Why is there a problem?
Yeah,
I don't-
it's
I
only
think she-
18,000 jobs at
I'm-
stake. So
Again, this is what,
Okay,
maybe overboard.
okay.
no,
okay.
no, so she is just, apparently, according to
She-
John, she's concerned that biotech companies wouldn't want to have to comply with this, and so they wouldn't come to our state, is what she was afraid.
Wouldn't
No,
want
she
to
was
comply
concerned
with the
about the data.
reporting?
If
Well,
there's a
no, I
ban-
have a question.
ban.
So I think we need to get clarification from Chairman Hunt if he had the direct conversation with the
Yeah, it wasn't
governor's
me,
office.
I'm just secondhand.
So
guy.
the question is the reporting, the reporting is all confidential and anonymous.
Mhm. And there's a penalty if somebody were to break that, so.
Right. So the question is, do we need to refine this amendment further to say the only people that need to report are cosmetic companies?
Well,
I
that
think
is the question for us to
No.
decide. Do we want to do that, or do we not want to do
But,
Yeah.
that?
I think we
Too.
just need to find out if there was that.
No, that is,
It is?
that is the conversation that he had. So she apparently won't sign this. This is according to what she told John, and John told
Right.
me.
Well, I just wanted to hear from him if he.
That's fine. But I guess, I mean,
interpreted-
we can still have that conversation now. Like, if you guys like this, what I did, we can just pass it and say this is the position of the House. Like, I don't think we need to. I mean, I think it's reasonable, and if she vetoes it, that's okay. I mean,
Well, I do too, but when he gets here, we could just say, you know, is there further information that you have that might be important for us to hear?
Yeah.
Otherwise, I think you put the safeguards in.
I
for the
put some good
confidence.
safeguards. I thought it was pretty good. It's not, I don't think it's particularly controversial, and I think if the goal is to get full info on what's happening in our state, then this will accomplish that. And then if in the future, the Humane Society has these reports, and they can say, listen, this is a real problem because of X, Y, Z, then we can have better regulations around animal testing and humane treatment, which I think most people want humane treatment of animals. And so, but I think putting in a ban, which was always my concern with the bill originally, is putting in a ban is like, it's like having the cart before the horse, because we didn't actually know
But this
the
gives
scope
us
of what's
the
going on. This
data.
will get us to figure out what's happening first.
Right, let's get the information,
Yeah.
and then, as a bill, which this does, and then if there's further action, we can work on it next year.
Yeah, that's the goal of this.
And
Perfect,
it does include institution of higher education, so
It includes everything, yeah.
everybody's
We did-
included.
everybody
The goal is to get
included.
collectively what's happening in the state, doesn't matter who's doing it. It'll be aggregated up so that these companies can remain anonymous. And then we'll know that there is or isn't a major problem that needs to be addressed in the future.
Okay,
Yeah, I think that
Good.
is what,
Well, it'll be in there.
No, not testing, torture.
okay, let's move on. Let's see, 544 has an effective date change as an amendment, and that's all it has.
Representative Tuesday, I just told Kristen that there are two bills, the effective date changes are incorrect.
Well,
So
like I
for
said, I wouldn't be touched by
544
this,
And 550.
because this is.
Yep,
stuff-
550's next.
They should both be January 1.
I'm doing them in numerical order.
That would be a different
There's a
amendment, I
problem.
guess.
It should be January 1st, not July 1st.
we need an amendment.
So Kristen's gonna fix
What's-
that.
What's the problem with changing the date to July 1st?
It's not,
Doesn't
it's supposed to
coincide
be
with-
January something.
Well, this this bill is so that they can do formulary changes, but not annually. They want to do formulary changes mid-year.
Then there's another amendment needed on top of this one.
Yeah, so for both of those bills, the amendments should be to January 1, 2027 to align with the start of the new plan year.
Could be in tomorrow? Oh, hold on. I have further information on Chairman Hunt. His car broke down. Alex is on the way, Adam is on the way to rescue him. So I have no clue, and that's just what he told me. His car broke down. He's going to go rescue him. And knowing the age of his car, as good of a car as it was, it deserves to die a graceful death. Yeah, we're going to keep going. Okay, these two amendments are going to need another amendment for tomorrow for changing the date to January, 28,
January 1, 2027.
2027.
Yes. So right now they're July 1. They just need to go to January 1.
Oh, they go back to January.
Which,
Yes.
sorry,
Okay.
what bill are we on?
Very good. I like that.
544, SB 544 and SB 550.
Yes. 550 and 544. I told you, I'm taking them in numerical order, that I have them. All right? Okay, 1-1. Today is just subcommittee. No, we're not going to. No, this is just an amendment review until our chair can. Yeah, we can, but when he comes in, we can just rip right through them. Okay, the next one I have is the amendment to SB 573, which is amendment number 1675H. Certifying Center of Public Safety for Comfort Dogs. All right, is anybody on the committee have any issues? Does anybody in our group have any issues with Amendment 573?
Good, because that avoids a 30-minute conversation.
Well,
No questions.
okay. Did everybody have a chance to go through it? Well, I went through my email, which it came in 2 days ago. Okay,
Sorry, which one are we on?
we're on 573.
Did we hear anything from any of the Comfort Dog folks?
Yeah, there's,
And they're fine
anybody,
with this?
if you can, you don't have to have a pink slip. Just come on up and,
If you're just
you know,
fine with
share,
this, that's all
share
we
what you
know.
need to share with us.
Where's the comfort dog?
You want the dog?
I want the dog. Okay.
Remember, I have an hour to kill. Okay, no problems with 573? All right.
I mean,
See, I reviewed all these when I printed them out, so.
No, I know, but
You do too.
sure exactly what changed.
All right, well, if you look through it and see something, let me know.
It was all, the amendment was all. The amendment was when Officer Justin came here with the dog and he pointed out all sorts of spelling errors and grammatical errors. So
Yeah,
it was
yeah,
just
this
cleanup.
corrected
It
that.
was just cleanup. That's
This is a
all it was.
cleanup amendment. Okay? But if anybody has anything with these, just let me know. Put your light on. Let me know. This is an open review. This is the first time we've done this, so it's not formal. All right. Amendment to SB 606, number 1685H, relative to biomarker testing under the state Medicaid program.
Comment?
Okay,
I've been told that there is still some issues with it and that we would like ultimately to interim study it. So we need to do some more work.
this
Or
may,
we don't have to do some more work.
right, this may fly with the amendment, but
Right.
it'll fly as an interim study bill.
Yeah.
Okay.
Do you know what,
No,
Do you-
I'm an OTP on this bill.
do you know what issue, so in my notes, I said the amendment needs to move the move the section to the Medicaid statute 167:1.
I think I saw the young woman that was dealing with Alzheimer's. You want to come up and tell us what the problem is?
Just so you identify who you are. There's no pink slips.
Jetty Horgan with the Alzheimer's Association. Thank you so much for the opportunity to speak with you all. We have some challenges with the language that is, this bill was brought forward at the request of the Alzheimer's Association, the American Cancer Society, and a bevy of other organizations that are looking to expand access to biomarkers. We really appreciate the work the department did with us to try and find some language that we can all agree on. Unfortunately, we were not able to get there, so we would love the opportunity to continue to work with the department on the bill and see if we can find a place over the summer and the fall to get to some kind of language that we can all agree is appropriate and effective.
So you're requesting an IS?
Yes.
Okay, but is there an area in the amendment or the bill that you have issues with that you
Yeah.
could help us with so we know what?
Yeah, so
what to
specifically,
study?
our concern really focuses on the language that says that the Medicaid department will determine what biomarker tests are covered. So our interpretation of that is that it still just continues to codify current practice where Medicaid makes determinations about what biomarker tests are covered. And so we are advocating for increased access beyond essentially for all biomarker tests with the parameters and limitations that were in the original part of the bill and not having a determination separately by Medicaid put into statutes.
So this would put in more of the Medicaid codes that are not being covered right now.
Correct, yes.
Okay.
But
That's why interim study would be recommended.
so we would respectfully request the interim study in order to give us some more time to get to a point where we feel like this would be achieving what our coalition is looking to achieve.
Right,
Okay.
but within the parameters of the Medicaid program, right, isn't
So
there a
the
federal issue?
So there are parameters within the bill as initially introduced that, require scientific evidence and FDA approve, some other language in there that really limits it to medically appropriate. We just are hitting a snag on the medically necessary determination by the departments that we're concerned about.
Okay, thank you.
Okay,
I got a problem with
go ahead.
this. The,
Pull the mic closer.
I don't think that we should stop somebody doing what they're doing now and waiting for the information that somebody else wants to get into the game. And it sounds to me like Medicaid knows what they're doing. There are people that have, high quality people. And for some reason, there are some people that this lady represents who wants to stop the use of the biomarkers.
No,
no.
I'm so sorry for the confusion, Representative. So we're not looking to stop anything. The bill was initially our request with the American Cancer Society and these other organizations to expand access. And our concern is that this just codifies current practice and doesn't actually expand the access that we're looking for. So we are not looking to stop any type of coverage of these biomarker tests. And we do, want to continue to work with the department because we're not, everyone is coming with good intentions and wanting to ensure people get appropriate care. And it's just a matter of finding language that achieves that from our advocacy position.
So the current situation
Would it not
goes-
change?
Will not change.
Correct. If we interim
just
study
gonna
this bill,
add
nothing will change.
More codes.
Well, yeah, I think I know what's going on, but I just don't want it stopped while
Right.
we wait.
I agree.
Of course.
Very good.
Yeah.
Thank
Okay.
you.
All right. Thank you so
Any
much.
questions? Okay, thank you, everybody. Okay. Amendment to 614 changes the effective date to July 1st. That's good. Any questions? Hope they don't run out of stuff to do. Okay, there's a good one. 665, Amendment 1687 replaces the bill. Thank you, because I couldn't explain it.
Good morning, everyone. I'm Michelle Heaton from the New Hampshire Insurance Department. Just to give a little background, this is a bill that came over from the Senate that we worked with Senator Rochefort to help him draft. And what he was trying to do is there was a number of bills in the Senate dealing with PBM regulation and prescription drugs. And he tried to combine a lot of those concepts into one bill. And we assisted him in drafting that bill in a way that would actually be something that we could implement. That's as it was on the floor, I believe, in the Senate. There were a couple more amendments attached to it. And so what came over to you is the bill we drafted plus a couple more amendments. So when we spoke last, I believe Representative Hunt was not enthusiastic about this amendment or these changes. So we took it back and we worked with some of the stakeholders, and we have this new amendment. So I'll walk you through some of the amendment. What we did is I think we incorporated probably 90% of what the holdups were. And so for the most part, most of what's in here is a consensus where everyone is in agreement with these changes. So I can walk you, since we have plenty of time, I'll walk you through it.
One question,
Yes.
was Curtis involved?
Well, sorry?
Was Curtis Barry involved?
Yes.
Okay, fine.
Of course he does. Of course he does.
Okay, so starting in section 1, what this initial section does is it changes the definition of a PBM or a pharmacy benefit manager. Currently in 402N1, there is an exception. So if the health insurer that's licensed in our state has its own subsidiary PBM, it's not subject to the licensure requirements. We would be removing that, and even if the PBM is a subsidiary of a health insurer, they would still have to become licensed as a PBM.
Okay, good.
Section 2 is just updating the penalty amount from $2,500 up to $5,000. This is consistent with a change that's in our technical bill this year, and it was at $10,000, and we compromised and came down to $5,000. So we split the middle.
Per violation.
Per violation, yes. So, excuse me. Section 3 is a new part of 402N. This requirement mirrors a requirement that's already in 402H. 402H is with respect to TPAs, third-party administrators. And so it's taking that same type of concept. So there has to be a written agreement between the PBM and the health carrier that it is contracting with. And in that written agreement, there needs to be some certain requirements, really just a statement of what the PBM is going to be doing on behalf of the health carrier, requirements that the PBM maintain records and complete books so that the health carrier can go and audit them and make sure that they're operating within the context of the contract, and instructions for how the PBM is to operate. Again, these are very similar concepts to what's in the TPA statute. What we did remove from here is the requirement of fiduciary duty. That was a topic of some contention, but we believe that what's in here is really getting at the crux of what everyone was concerned about. As far as we're concerned, the PBM is operating on behalf of the health carrier, and the health carrier is responsible for everything that the PBM is doing. And that type of language remains in here, even
have a
though that
question.
fiduciary duty has been removed. Yes.
Go ahead.
I remember, because I yelled at the hit chair because you were telling him, well, I can do this and this, and he was already beyond there. But my understanding is that in some cases, the pricing on the pills or whatever are higher than, or maybe brand name. In other words, yep, there's something else you could use just as well, but the deal is with the brand name, and that's what you get. And I thought that was should be changed so that if there is a
Generic.
that it should be on the list. And I just don't know if you did that.
We did not require that in this legislation. However, I'm not aware of any situations. There's a lot of formularies we'd have to go back and review, but oftentimes what's on the formulary is the generic because usually that is the cheaper alternative option. And so oftentimes you will see the generics available and maybe not the brand name. But either way, whatever is on the formulary, there is an exceptions process. So if someone needs access to a drug that is not on the formulary, they can request access through that exceptions process. And that exceptions process, they would outline why they need that drug and why the drugs on the formulary would not work for them. And then if that exception was denied, they would have the ability to file an appeal and to go to external review. So that mechanism is to ensure that everyone has access to those drugs. Part of what they do with the formulary, whether it's the PBM or the health carrier, is there can be a number of different drugs available. They're trying to narrow it down to the ones that are have better efficacy, safety, and are cost effective. And then within the formulary, usually there's tiering so that the lower cost options are on this, depending on how you look at it, the higher tier or the tiers 1 and 2 that have lower cost sharing associated with it. So sometimes, the generic drug, there could be a cost sharing of $20, whereas the brand name drug, the cost sharing could be $50, something like that. And part of that is to incentivize people to go for the generic because it's less cost sharing on their behalf. Also included in our laws already is a requirement that the pharmacist can only charge their usual and customary rate or the copay, whichever is less. So if the drug only costs $5, but the copay is $10, the pharmacy would only be able to charge that $5. Does that get at your concern or not
Don't
really?
worry, you're trying.
Okay.
John, I have a quick question.
Yes.
Are you,
Comes down for Charlie.
are you, okay, thank you. Thank you for the explanation. So for the, on page 2, line 17, it outlines very specific reporting requirements. Are these reporting requirements currently in existence and this was modified, or is this a new reporting section?
So in 402N, there are already reporting requirements. However, this section is a replace all. And so they're similar reporting requirements, but we feel like these are more robust
Yeah.
set and are really going to get to the type of transparency that we want to be able to provide.
And follow up, please.
Go ahead.
Can you help me understand, there's a lot of data here. Can you help me understand how the department will use this data?
So we use this data in our transparency efforts around health cost and health cost drivers. And so part of what we're trying to get at is within the entire market, how much is being spent on prescription drugs, how much money is being recouped through rebates. And so you kind of need that to figure out the net cost of the drugs. And so that's a lot of what we're trying to figure out here is, and some of the fees associated with using PBMs. A lot of what's being suggested in terms of legislation, just not only in New Hampshire, but across the country, relates to some of the rebate arrangements and fee arrangements for PBMs. And so if we have better data on those things, then that will help stakeholders and lawmakers figure out where we need to make adjustments, if there are any adjustments that need to be made. It would also be helpful to entities out there that may be looking to use a PBM or a third-party administrator to help with self-funded to have some transparency around how some of these arrangements are working.
One more follow-up?
Go ahead.
And I
It's a
understand.
conversation.
Oh, okay, thank you. And I understand that you can only require the reporting for the areas that you have jurisdiction over. So for the exceptions, do you think that's a problem with the data collection in page 3, starting on line 13? Is there any issue about not being able to collect this data?
No, this is currently in our statute. It just got rearranged. This whole section just got rearranged, so it just flowed a little bit better. In this amendment, the only thing we've changed is changing it from semi-annually to an annual report. But these exceptions already exist, and there's some good reasons for it. Self-funded plans operate differently, as does the state employee health plan, Medicare, and Medicaid. Medicare, obviously, there's the Part D plans, and there's separate data reporting associated with that. And Medicaid, we already do get some data through the Medicaid Managed Care Program. They do report into the CHIS. So we do have some data, but the way those plans are structured is just very different than the fully insured market. So it's a little bit of an apples to oranges comparison sometimes. And also, we just wanted to avoid any litigation where we could be preempted by other laws.
I'm just looking at the effective date. And you would expect the first annual report in 2028?
Yes. Yes.
Yeah, they got what, 1 year to do it.
Yes, and we are already reporting data on these issues,
With
but
all
for
this
this specific
robust-
data set, then
Right.
yeah, it would be January, or not January, but it'd be 2028, spring of
So it
2028.
gives you a little bit more granular data.
Yes.
Okay, thank you.
So that takes us through section 4. Section 5 just cleans up some of our examination and investigative authority, just to make very clear that we have the ability to examine it. This has not been an issue in New Hampshire, but it has been an issue in some other states. And so we just want to make sure that it's very clear we have the ability to examine these entities. Section 6. So one of the things we did do is with respect to, I believe, SB 544 was another bill that you guys already, I believe, passed and exec that had to do with prescription drugs. And so that same language was in this bill as well. We've pulled out that language now, so that removed a couple of the sections that were originally there. However, there is another, some more amendments to our managed care law, and this is where we kind of transition to things that are not PBM specific, but are more about prescription drugs. And so it's changing the managed care law just to really clean up some language. There were some references where it just said PBM, it really should be health carrier or PBM. And we're just making it very clear that these types of adjudications are subject to 420J due process requirements with respect to adjudications, appeals, and utilization review. It also puts in a requirement that if there's going to be an audit of a pharmacy, that there's at least 7 days advance notice, and they can ask for an additional 7 days. Section 7 then just makes an amendment to our retroactive denials and states that if the health carrier provides notice that they are going to retroactively deny something, there is a 15-day notice that's already required, and if they appeal it within that 15-day notice, then they can take back that retroactive denial until the appeals are complete.
Good.
And then the last section is section 8. It adds a definition for spread pricing.
Okay.
And it's really just to state that if there's going to be spread pricing or the arrangement between the PBM and the health carrier, that with respect to group plans, that arrangement needs to be disclosed to them. So it's just really just a disclosure requirement. It doesn't prohibit spread pricing. And then it's effective January 1.
Does anyone have any questions? I think this is a very good review. Okay. He needs to know what that spread price.
Yes, yes. So we're adding a definition, and it means a model of drug pricing in which the PBM charges the health benefit plan a contracted price for drugs, and the contracted price differs from the amount the PBM directly or indirectly pays the pharmacist. So that differential is what you call the spread pricing. It's an arrangement, a compensation arrangement, one of many different kinds that can be used to compensate the PBM for their services. But it relates to the price of the drugs as opposed to just a flat administrative fee. And so this amendment is just saying if that's how the arrangement is set up, it just needs to be disclosed to the group plans.
Spread pricing is a way to keep the real price a secret.
Okay, any questions, comments?
Well, do you want that disclosed in your reporting or no? That's not applicable.
I I don't think it's currently in there.
I
This
didn't
is
see it.
to address some of the concerns that were in some of the Senate bills. We don't take a position on it. So we helped draft this to
No, I
get,
understand. I
yeah.
didn't know if you wanted data on the spread pricing in the report.
we believe that the data being reported is sufficient as it's laid out in that section. And so we wouldn't need anything additional.
We might want to think about it.
Well, that's the next bill for next year. Thank you very much.
Can we hear from Curtis?
Good, Representative Spear.
Spread pricing is a mechanism, PBMs have a couple of ways they can charge. When they have a contract with the carrier can say, you cannot charge any more than, let's say, 5% over the drug price. And that's what they'll do. You know, it's a fixed fee over a fixed price, and they go along with that. But there are some carriers that might say, well, I don't care what you charge, just make sure it's 20% lower than the market. And if you can save more than 20%, knock yourself out. But I'm only going to pay you 20% over market. That's spread pricing. So this gives the carriers a little more flexibility, and it really shows up, spread pricing really shows up in the ERISA market, because that's where the employers are now responsible for the cost. And they can say something like, I don't care what you charge, I want 50% below market. And this gets them a boundary on what they're going to be paying for drugs. So it's really up to the contract as to whether or not this is going to be used. It's not something somebody makes up willy-nilly.
Thank you,
Carrie, do you
Representative
think
Spear.
that data would be important? I mean,
Oh, yeah, sure, the data reporting is fine. I think that's a good idea.
it's not currently, but I don't know if that's really just proprietary for, a discussion.
Somebody here
and-
could tell us if that kind of information is proprietary. It's conceivable that it could be.
Or not really germane to what the department is looking for in order to monitor.
I don't know. As long as they meet the requirements of the contract, and they meet those requirements, and the carrier is saying, yes, you are meeting the requirements of the contract, I don't know how much further you have to go.
Okay.
You know, and this whole thing is driven by contract. It's not such something that just somebody goes and wings it.
Can we hear from
Okay.
Curtis? Can we ask Curtis to weigh in?
Curtis, could you come up? Thank you, sir.
You're welcome. Good morning, Mr. Chair,
Okay.
members of the committee. Again, I'm Curtis Barry here on behalf of the Pharmaceutical Care Management Association, PCMA, which is the National Trade Association for the PBM industry. Before I start, Representative Spear, I think you hit the nail on the head. Great description of spread pricing. I could not have done better. I can make a couple of comments and then answer questions if you have any. It should be noted also the sections that are no longer in the bill per this amendment, in addition to the fiduciary responsibility being struck, the steering provision, which was section 16, the last section of the bill, has been struck as well. And as Michelle Heaton mentioned, the reporting requirements were changed from semi-annual to annual, which was our request as well. I should note that those are the primary concerns of PCMA, but I know PCMA members, at least one, have some remaining concerns, if you would hear from them as well. Other than that, I'm happy to answer questions.
Okay, Representative Herbert.
Now, I know what fiduciary
Put your light on.
responsibility is. And that kind of makes me question. In other words, on spread pricing or whatever, what the deals are. But, I mean, for example, if you're a stockbroker, you have a fiduciary responsibility for your customer. And that's big. So somebody wanted to strike it or did strike it? Why?
Because what runs the transaction is the contract. They have to meet a contract. That's their responsibility, to meet a contract. This fiduciary responsibility to do the best for the patient, that's not who they have a contract with. They have a contract with the carrier or the employer, depending on what kind of insurance you have. And so they have to meet the letter of the contract. That's what they have to do. Now, if you don't like the contract, go to a different insurance company. You always have that right. But within that insurance company, that's who's controlling what is happening.
I still think that's a bad deal. Because
Well, you
they'll
are a
take
socialist,
advantage
so
of
that's
it.
okay.
And you're not gonna look at a contract. Well, you might, but
You
the
won't.
fact of the matter is, 99.9%.
No, this is where you
of them-
pick your insurance company, and either you trust your insurance company with your health or you don't.
Most people do
Then
not have a
that's what- then
choice
that's
what
what it is.
insurance company they
Then you
pick.
don't.
They have to go with their employer, yeah.
Okay,
I-
by the
if-
way, this is a conversation.
Yeah.
That's all this is.
I appreciate that. If I may, to add to that, fiduciary implies that the PBM would have discretion over what happens. And they don't. They don't make decisions independent of, in this case, the contracted health carrier. The health carrier, to use an example that was discussed before, the health carrier has complete purview over what's on the formulary, the tiering, et cetera. The PBM does not make decisions independent of that, which is what fiduciary implies. PBMs are not fiduciaries.
But isn't there a conflict of interest with the vertical integration?
I can't comment on that. That's a matter of opinion and subject to, of current federal legislation.
Okay, any more questions, comments?
So you've read through the amendment and you're in agreement with the changes? Or are there
Yeah, we
areas
appreciate
that
the
someone
effort.
else would have comments on?
Right,
Is there
exactly. I
anyone
know,
el-
yeah.
okay. No, but
we
you're
have members that have remaining concerns.
in any particular section or,
I would ask them to,
okay,
expand on that.
all right, thank you.
Sure. Thank you for the opportunity.
Okay, Curtis, thank you very much.
Thank you.
All you gotta do is raise your hand and come on up. You get recognized. This is a conversation, guys.
Good morning, Representative Patusek. I'm Cam Lapine. I work at Orin Reno, here representing Cigna. We do appreciate the work that the department did with us on this bill. So there are two areas that I do want to point out that are still of some concern for Cigna and Express Scripts. The first is in relation to the fines. So the department did bring the fines down to 5,000 from 10, which we do agree that was supportive. And does align with the technical bill. However, the amendment 1687H does still say that each day of noncompliance shall be considered a separate violation, which is not what's in the technical bill, HB 1197. That language was in HB 1197 as introduced, but this committee removed that language from HB 1197 when you passed it. So we would request that the fines be 5,000 per violation, and not a continuing. And so that language appears on page 1, lines 23 and 24, and then it also appears on page 5, line 17. So that's the fines, $5,000 per violation. The second piece that we still have some level of concern with is on page 2, lines 11 through 14. So this section requires that a health carrier shall, at least semi-annually, so at least twice a year, conduct an audit of the operations of the pharmacy benefits manager. As an organization that operates also a health carrier, having that mandatory audit every 6 months seems burdensome. We had suggested originally replacing that shall with a may, every 6 months. We had suggested maybe leaving the shall, but then saying if the healthcare and the PBM reach a different agreement in their written agreement, the written agreement shall control, recognizing that they're two sophisticated entities. As long as there's some kind of oversight there, that would be agreeable. We just feel that having mandatory audits at least every 6 months just creates unnecessary burden and administrative oversight for the two entities there.
Okay,
So-
was that shall in the original bill?
Yes,
Okay, and we changed it, it stayed shall,
yes,
okay? And that came out of the Senate side,
yes,
and you would like to see it go to May.
yes.
This may come out in committee of conference.
I have a question.
It didn't change, right? Is that
No, it didn't change.
Yeah.
Representative Miles.
Thank you for taking my question. So to clarify, your position is oppose this amendment. Is that correct or not?
No, this amendment is better than the bill as it came to you. I'm just pointing out two additional areas where perhaps further improvements could be made.
Thank you.
Yes, Representative Burrows.
Thanks. You're talking about the civil fine, you wanted to change that, but what happens if the violation continues? What are you recommending?
Well, ultimately, the commissioner had the authority to revoke a license.
Okay.
That's the commissioner's authority.
Okay.
John Hunt's law. Don't forget.
Licensure, right? Got it? Okay, thanks.
Everybody okay? Thank you, sir.
Thank you.
Appreciate that. Okay, come on up. Just identify who you are when you hit the mic. And press the button to get the red light on.
Okay, I'm not used to this.
There we go.
Good morning. My name's Jeb Krolop. I'm a private citizen from Nashville. I've lived in New Hampshire my whole life. This bill really, its initial intent was to allow the lowest available price to consumers. And I personally found out that, that the pharmacy will not avail customers of the lowest available price. A customer is obligated by their insurance carrier and whatever the contract is. Now, I'm going to give you a simple example. I went in the pharmacy to pick up 3 months supply of Ezemtib, a high blood pressure drug. The pharmacy I was using at the time, we were with Anthem, and they told me I owed them $95. Because a very nice clerk in the pharmacy, at risk of losing her job, told me, I can give you ask for a lower price. I said to her, I said, okay, is there a lower price? She said, yes, I can give it to you for $35. So because I was made aware that their lower prices are available, I saved $60. I have since done that many times, and I've had many savings as a result because I knew to ask the question, are there any lower prices available? Now, most people in this state do not know that there are lower prices available. They trust their insurance companies, but those deals or plans are contracts, and the pharmacy will not automatically make available to customers the lowest price. Now, this bill originally, 665, it had the second highest bipartisan support in the legislature. It was supported by Republicans and Democrats, the House, the Senate, and from there were two other bills that were merged and with it. And it then passed with an amendment. We had some watered down language on actually making the lowest price available to consumers. It then required the pharmacies to put up signage or to tell customers that they may have lower prices available. Now, in the quest to lower healthcare costs, not only in New Hampshire, a whole country, the United States, we spend 20% of our gross domestic product on healthcare. The Japanese spend 10, and they live 5 or 6 years longer than we do. The Europeans spend somewhere in the teens. The United States does not do healthcare well, and it's because of all of this self-dealing that is built into our system that we have to get rid of. And so allowing the public to be informed of lower prices is going to be the road to one step in the direction of lowering the prices of healthcare in the United States. So I would really just ask each and every one of you, you all look younger than I am, but most of you,
No.
but
News for you.
if you're on medications, have any of you asked your pharmacy when you went in there, are there lower available prices? I think you'll be pleasantly surprised that there are. And everybody in the state should have that privilege, or they should be aware of it. And I really respectfully and beg this committee that you will add back in that section 16, which is on the steering. And I really appreciate what Representative Herbert, you get it. And I think you all do. And but I was not here at the last hearing, and I listened to it and watched it. And I sent in testimony, the original, when it came over to the House. I don't know if you read that or not. But it's important that people are aware of lowest available prices for their prescription drugs. It's going to lower healthcare costs, and I ask for your support on putting that section 16 back into this bill. Thank you very much.
Well, thank you.
I
It's
ask a
the old
question?
standard, let the buyer beware. Representative Mills.
Miles.
Miles, I'm
Thank you.
sorry.
Thank you. Thank you for being here. So I heard you say the original intent of the bill is, if I understood you correctly, is not represented in what we have here now. Is that correct? Thank you.
Except for the number. That's
Right.
all that remains of it.
Yes, thank you.
The title, the content, everything else has been eviscerated.
Thank you.
Yes,
I just have
Representative
a,
Porcelli.
I'm sorry, Carrie, go ahead.
Just said we do that all the time, that's all I said.
I do have a question about the process. So I was not aware of this, so thank you for educating me. I don't understand what the process is or how it works to have customers ask for a lower price. So if you could, or if anybody here could help me understand how that works, I would
just ask.
appreciate that. No, I want to understand the process behind it and what happens.
It's really, I found it to be quite simple, and in how powerful it is, that if you're on Cigna or Harvard or you're with Anthem Blue Cross Blue Shield, they have contracts with the pharmacies and the pharmacy benefit managers. So when you go into the pharmacy, according to your plan, they've already got pre-negotiated prices for your drugs. That pre-negotiated price is not necessarily the best price for you. As I demonstrate my example with the ESM team, I got it for $35 instead of $95, $60 savings. That was one prescription. And if you don't ask for the lowest available price, you won't get it. And they'll give you the price from your health plan.
But was it from a rebate or a coupon? Or,
That's-
how did that
It's very, it's like a game. You probably have seen all this Good RX, and you have, rebates and discounts and coupons. So when I go into the pharmacy, I ask, do you have any, I want the lowest available price for my medication. Do you have any rebates, discounts, or coupons? And you got to ask that. If you don't, the law is written that the pharmacy, it's in the pharmacy laws right now. They don't have to tell you. They only have to tell you if you ask. So
But for your
that's,
specific medication, you're not saying, is there a generic that's less expensive? You had a specific brand,
right.
right?
And
you
and
said,
that,
is there, for XYZ drug, is there a coupon or a rebate or a lower price? That's the specific question that you asked?
that's right. And I didn't even have to get the rebate, discount, coupon. There's so much going on behind that, screen with the Wizard of Oz.
Well, that's what I'm
That-
trying to understand.
Right. And so if you just ask for it, they'll find it, and they'll go into their cash register, and literally within seconds, they'll find it. It's not laborious. It doesn't take time. And we would like that all consumers are availed of that that there's a mechanism in there, some mechanism, so they have that protection and the lower price advantage.
I just want to make a comment.
Can we ask her? Oh, I'm sorry, go ahead.
I just want to make a comment. I don't disagree with anything you say, and I believe that people should be told that. I'm just very pleased my Hannaford market where I get my meds always tries to find the lower price. Maybe just they're good at that particular store.
But they won't, they won't do that automatically. I mean, they're very nice. Oh,
Press the button.
is that better?
There you go.
So, no, they won't. And I actually came upon it because of a very nice clerk who
No,
whispered
I'm
to
saying
me.
my clerks do that. They just, maybe they're trained to do that or whatever, but not disagreeing with anything.
Yeah, and when I asked the clerk, I said, well, why don't you do that with everybody? She said, it's against company policy, their policies, internal policies against doing that.
Yeah, I know, 'cause I go to Hannaford. Go ahead, Representative.
Carrie, is it okay if we ask Curtis to comment on that?
Yeah, sure, but I would like Curtis also, when he comments, is to indicate, well, first of all, PBMs and insurance companies don't necessarily have a contract with the pharmacy. So the pharmacy is free to do whatever they need to do. And so your comment that the insurance companies have a contract with the pharmacies, they don't. PSAOs have a contract with the pharmacies, sort of. And Curtis is shaking his head. Why don't you tell us about that, Curtis?
Okay, hang on just a second. Oh, by the way, it's January 1947.
Birthday?
I'm older than you.
Okay, June 29th, 1960.
I got 3 years on you.
I'm older than you.
I told you this was a conversation. This is as loose as we can get. Thank you. Curtis, you want to come on up? Okay,
you.
specific questions?
Well, let me, if I can clarify
Go ahead,
some
and
things first.
then-
Yeah. Actually, there has to be a contract between somebody and the pharmacy, whether it's a PBM or the carrier or if the pharmacy network, if it's a chain. PSAOs, I believe, operate on behalf of independents and will be the intermediary negotiating a contract between an independent pharmacy and the PBM.
If the insurance company has a contract with the pharmacy, how is it that you can go to any pharmacy you want?
Well, we're getting into a different area, and I'm going to use a term, I know Michelle doesn't like me using this term, but we have what we've always referred to as an any willing provider, any willing pharmacy statute, which has been on the books for a very long time in New Hampshire, that basically says if a pharmacy is willing to accept the terms and conditions of a contract, they have to be in the network.
Did they
Which is
sign a
different.
contract, or did they just have to turn?
No, they
accept
need a
certain terms?
contract.
Oh,
They
they
do
do.
need a contract in place. But as far as one of the things I wanted to comment on was the premise that the PBMs or a carrier tells the pharmacy, you can't discuss this with the patient. That is absolutely not true. And I know the hearing was rushed, but there are two provisions on the statutes currently that address this area. One is 41526, which is in the insurance laws. And this was, way back when, a request of the pharmacies at that time, primarily the independent pharmacies. It says, a pharmacy benefits manager or insurer shall require a contracted pharmacy to charge an enrollee or insured person the pharmacy's usual and customary price of filling the prescription, or the contracted copayment, whichever is less. That's a requirement. So the PBM or the carrier has to tell the pharmacy to charge the patient the lesser of the two. That's the first piece. Second was also a request of independent pharmacies, which is, it addresses a practice that we refer to as a gag clause. And this is in 420J8. It says, no contract between an insurance carrier or pharmacy benefit manager and a contracted pharmacy shall contain a provision prohibiting divulgence to a covered person or the insurance department relative to monetary matters which would prove beneficial in lowering the cost to such covered person. So in other words, the PBM or the carrier cannot, according to the statute, tell the pharmacy, you can't discuss that with the patient. Now, there's no requirement that they do, but this is in place because apparently there were some pharmacies that were doing this and wanted to make sure that there was no prohibition. So that's what I know. I hope
Okay.
that, Representative Porcelli, I hope that was helpful.
Well, I just wanted to know about the disclosure request. So if a customer says, I'd like a lower price based on a coupon, a discount, a special that day, or any other savings agreement, what does the pharmacist, what are their responsibilities?
They're free to do whatever they wish. They're free to disclose or provide, pass along any information that they choose to the patient. I should mention, this section that's being discussed, Section 13, I may have misspoke when I spoke earlier. I just have my notes numbered. It is currently Section 13 of Senate Bill 665, which is before you. PCMA did not take a position on that section. But to answer your question, again, the pharmacists, as far as I know, and as far as I've heard, they do this in many cases. Discuss with the patient coupons, whatever that may be beneficial to the patient.
So you would have no issue if we said, well, we want this disclosure so that customers know to ask for the lower price, or to take out their Good RX card that I still have no idea how it works.
Right. And keep in mind that this is a directive on the pharmacies, so there's no impact to who I'm here
Right.
representing.
Okay, thank you.
Go ahead.
If I may. Part of what I think you guys are talking about are restrictions or requirements on pharmacists. That is not covered in insurance laws in 420J and 402N. 402N and 420J are really specific to fully insured health insurance plans and how they're regulated. So if you wanted to put restrictions or requirements on pharmacists, that would need to go in RSA 318, I believe. With respect to the coupons, I think it's a little bit more complicated than just providing the lowest price. And in the fully insured market, there can be reasons why you do not want to do that. Some drug manufacturers may provide coupons to help people. However, when you use those coupons, you're paying out of pocket with your money, and that money is not going towards your out-of-pocket costs or your deductible when you use those coupons or when you use something like GoodRx. And so depending on the person's situation, it may not be in their best interest to do that, because if they have a high-priced drug, they may want to use their insurance to pay for this, because all of that cost are going towards their deductible and out-of-pocket maxes. And that will help them get to those maxes sooner so that everything will be covered. And so you see that it's much more in someone's interest when they're very high-cost drugs. For other drugs, like Mr. Berry mentioned, there are those protections where the pharmacist cannot charge more than what their costs were to procure the drug, or the cost sharing. So if the cost sharing is higher than what the drug actually costs them, they have to charge that lower amount. That is something we regulate in the insurance part of it, because that is part of what the carrier or the PBM would be doing if they went in to audit, is to make sure that that law is being followed. But some of these disclosure things, or what the pharmacists can or cannot say, or what they should be saying, is really outside the scope of what this bill is contemplating in insurance laws.
Quick question. So does the insurance department regulate RSA 318?
No, that's regulated by OPLC, the Office of Professional Licensure and Certification. They oversee pharmacists and the Board of Pharmacy.
Thank
Thank you. Representative Miles.
Thank you again. I think that many of us, and Ms. Eden also, has hit the nail on the head. The transparency piece of the PBM models is just that. There isn't any. I think we now are all more confused and have more questions than ever about what is the real price of a drug and why the patients aren't getting the lowest price in the first place. So based on that, I don't think this bill in its current form supports patients getting the lowest price. And for PBM reform and customer service and patients, and this is not going to do it. The bill in this form is not good.
Okay. Come on up. What you used to say on the game show, come on down.
Come on down. Thank you, Mr. Chairman, members of the committee, Mr. Temporary Chairman, members of the committee, Peter Bragdon, representing.
Chairman Pro Temp.
Exactly. Representing the state's non-for-profit insurance carrier, Harvard Pilgrim Healthcare. With just some comments, I think, as I mentioned to this committee before, is unlike a lot of other insurance companies, we are nonprofit. We're not national. We don't own our own PBM. So we've been just kind of monitoring this bill because it shouldn't affect us because we don't own a PBM, and just watchful for things that may affect us. And the department's been great to work with, and the stakeholders have been good at dealing with that. I want to echo the concerns that Cam Lapine had brought up, specifically regarding the auditing piece on page 2, lines 11 through 14, which currently the bill that came over from the Senate said that the health carrier shall, the insurer, in other words, Harvard Pilgrim, shall at least semi-annually conduct on-site or virtual audits. The audits are very time-consuming and intensive and require a lot of preparation work in advance. In the terms of health insurers and PBMs, both sophisticated buyers, both have contract lawyers looking things all over to make sure that both sides are protected. In our contracts, we have regular, almost daily reporting of various things going on, as well as weekly, monthly meetings to go over things. We have the ability to do market checks at any time. I really think having that be a shall would provide more flexibility. There may be smaller companies, self-insured companies that are using PBMs that need a little more protection. But in the case of larger groups, you're really talking about a couple of sophisticated buyers. And a lot of work goes into an audit that, having the right to have an audit is great, but forcing an audit to happen every 6 months just because doesn't seem right. So if you're going to force it, maybe make it a year like most other audits, or just have it be a May so people have the ability to do that. That's the only comment that we would have.
I have a question.
Okay, yes, sir, Representative Herbert.
Medicaid, Medicare. Public entities, not private. Am I correct?
Yes, Medicare, Medicaid, public entities, publicly funded.
Okay, so does this public Medicaid, Medicare organization get the lowest price?
I have no idea how the pricing works. My comments are specifically related to the auditing clause in the bill.
Okay, if you don't know, that's fine.
Oh, no, yeah, no, I don't know. That's, like I said, we're not directly affected by this bill because we don't own a PBM. We're just watching for things that, suck us into a lot of things that may not apply.
I was just wondering that the government buys in quantity, and I was just wondering if there is, as an ability, as a concept that exists.
For
Why
the
the
drugs,
hell are we gotta need private?
for the drugs that
businesses?
they have a contract, they have negotiated specifically with certain drug manufacturers like Lilly and whatever for, diabetes drugs. They can have a specific contract. But if you are on Medicare, you cannot use coupons. So you're not going to get that advantage. And whether or not they get the lowest price, I don't think so, because I got some drugs that are costing $1,000 a month, and I know that's not the lowest price. So I don't think they do that.
So it's Medicare, are you on Medicare or Medicaid or anything like that?
Depending on the drug you're taking, I don't think you're going to do that great, and they don't cover half the stuff, so that's
So
the other problem with Medicare.
just a brief question. So you're saying this would be a lot more onerous on companies such as yourself?
We believe, thank you for the question. We believe requiring audits every 6 months is onerous.
Thank you.
Okay.
Thank you all.
Okay, thank you. Okay, just my opinion. It looks to me like 6:65. Not ready for prime time. That works for me.
Only in commerce.
Okay, that completes our review. The last two I have are just amendments on 665 and 256. What happened to 498? There is no 498 amendment. I'm just going through amendments.
Oh, all right.
The only ones I got. So if there's other amendments out there. Okay.
Is there anyone in the audience that is speaking on behalf of, can speak on behalf of 498? Please come up, yes. I'd like to hear your side of it.
Okay, we don't have an amendment on this, right?
Oh, sorry, no.
We just want to talk about 498.
Yeah.
Okay, that's good.
okay.
That's, like I said, this is a conversation. Okay, what is your question, issue, whatever? Light?
There's just been a lot of dialogue, and so I would just like you to perhaps frame it very briefly and why your position is ought to pass and how it's important, how we can do that.
Sure. Thank you very much for the opportunity to chat with you all. My name is Michelle Merritt. I'm the president at New Futures, and joining me is my colleague Emma Savini, who is our Children's Behavioral Health Policy Director. So this particular piece of legislation came from a long series of conversations that had started back in 2020, 2021. Around this issue of a gap in private insurance coverage for children's mental health services that are specifically this program called Fast Forward. It's a wraparound in-home service that is the thing that essentially keeps kids from hitting higher tiers of care. In the Medicaid program, kids have seamless access to all 5 tiers of children's behavioral health care. Tier 3, which is the one that we're talking about here, is that middle piece that keep kids from hitting the highest level of care, which is psychiatric hospitalization. So they, in Medicaid, can move seamlessly between the tiers, but within the private insurance context, there is not currently private insurance coverage within the plan for this array of services. There have been ongoing conversations about how we can go about getting those services covered. And over time, they just sort of have not moved forward in the way that we would have otherwise wanted them to have moved forward. There's also challenges in ensuring that the service array is covered by a wide variety of insurance types. So the fully insured market, the self-funded market, as well as out-of-state plans. This state and its understanding that all children benefit from this program did end up funding the privately insured children with a $2 million general fund appropriation a few years back. And we're looking to sort of right-size who is paying that. Should it be the taxpayer through a general fund assessment or appropriation, or should it be the carrier through either an assessment or coverage within the health plan? So there have been fits and starts to this that have happened over several years. Many of them have originated in the Senate, and the most recent was folded into the last version of the budget, but ended up getting pulled out due to conflict with House Rule 50. But that's sort of where we are and why we had put the bill forward. I will share, I understand that there have been some conversations that have happened recently, and there's the department may be able to specifically talk about some of that because they were in the room. I was briefed by the department about where some of those discussions have been just yesterday. And I know that there is some progress that's being made, but in our position is that it's not enough to warrant this bill not moving forward. I think there are some things that the committee could potentially explore doing, like creating an exemption to pieces of the assessment for carriers that end up voluntarily bringing these services under certain plan products, and we could sort of work out how that would make the most sense with an amendment. We do have some ideas for that, but that's essentially where we are right now, and at least our position.
Thank you very much for the explanation, and I think that it would be great, if it's okay with you, to hear from the insurance department about those discussions, since we did get a message from the commissioner about the you might be very pleasantly surprised about the progress.
Yep, I have
that
had
okay?
the same conversation with them. I think he may have sent that message after he had spoken with us. So we are aware of the dialogue and the conversation have happened. I think
Okay.
where we may diverge is on the potential path forward. Our position is it would be most reasonable to amend the bill to recognize and provide a runway for further conversations, and not taking our foot off the gas and recognizing the importance of this particular piece of legislation and this array of services for these kids versus moving it to interim study.
Right, but the bottom line is we want the insurance companies to pay,
Yes.
private insurance companies
Yes.
to pay for covered services and not the state.
Yes.
Okay, okay, is it okay if we hear from the insurance
means.
department? Is that okay, John?
Yeah.
If we hear,
Oh,
okay,
yeah.
thank you.
This is reference to the bulletin we got?
Yes, yeah,
Yeah.
yes.
Yeah, I wanted to somebody to address this thing
Yeah.
too.
Good morning. For the record, Jennifer Smith, I'm the Legislative Director for the New Hampshire Insurance Department, and I'm joined by Deputy Commissioner of DHHS, Marissa Hens. So as you all got the email from the Commissioner this morning, well, for myself on behalf of the Commissioner this morning, so what we did
We
you have
also got the bulletin 214-016-AB.
Yes.
We got both of these.
Yes, we
So
can speak to both
You
for
can
clarify.
address, perfect.
Absolutely, sir. So what was alluded to is following last week's hearing that you all had on Senate Bill 498, the commissioner convened the group of stakeholders, so it was the insurance department, DHHS, the CMEs, and Anthem, who were the parties that have been working together to see, is it possible that the CMEs could get into network with the carriers so that an assessment wouldn't be necessary. A non-legislative solution could hopefully be found on this. These conversations, as you'll remember, have been going on for months. We started meeting as a group back in the fall. The departments stepped away a little bit to allow the CMEs and Anthem to try to negotiate and see where they could get, and things kind of stalled a little bit this fall. So we got everybody in the room after the hearing and on Friday and asked them, what is really the roadblock that exists right now that's preventing things from moving forward, either by the carriers getting, the CMEs getting a network or coming to a single case agreement on a particular child receiving these services that might shed some light in terms of how can the carriers pay for this. So we had that meeting on Friday. Those discussions went very well, we thought, and I'll let Commissioner Hens speak for herself. I don't presume to speak for her. But from our perspective, we felt that those conversations went very well. And that we understood pretty clearly what was the roadblock in place. Very fairly, the CMEs had some concern wanting to make sure that they were advising any of the families that were going to maybe potentially be looked at for a single case agreement. They wanted to make them aware of that. They wanted to be completely transparent in that regard, so there was no surprise coming to them that if they were going to move this way, that they knew, and they knew what that meant. So we heard that concern from Mr. Raynard with NFI. And then through this, they've been kind of talking to a little bit more, even still since last week, what are some of the code requirements that could be used to, or codes to be billed for. So it was a very productive conversation. It did not, for the group's perspective, and we were also joined by a representative from the governor's office at that meeting. It does not feel that we're too far away. So NFI is having that conversation with the family to make sure they're comfortable with their particular case being used to see if they can come into a single case agreement with Anthem. So I won't speak to that. Mr. Raynard can, if you want an update from that. And then Anthem is working with their piece from their side of things too. They had a few different codes that they brought to the meeting that could potentially help cover some of these things so that the array of services, as Michelle mentioned, stays the way that it is and is not unencumbered. So at this point, what the commissioner in his email to you stated is that, and what we provided in the bulletin is the list of codes that mental health services can be billed at. It varies by who the provider is, what the level of care is needed, the intensity of the care needed, some of those things. What has been discussed outside of that bulletin is maybe some additional like per month case rates, things like that. There are some codes that do exist that are not part of that bulletin that could maybe be utilized for this single case agreement so that we maintain that group of services and we're not having to separate it. But so that's kind of where we're at. The commissioners, what he had said to the group, what he wanted to see moved forward if the committee was of the opinion of interim studying the bill was to that he is committed, and he shared this with Representative Hunt, that he is going to follow this process very closely going forward. So if you all decide to move to interim study and are seeking a report in September, there's going to be a lot of milestones along the way between here and now that are going to be watched by the department to make sure that the CMEs and the carriers are talking. They're making progress, number one, toward this single case agreement. And then for longer term, seeing if they can get the provider as a whole in network by the carriers. So he plans to ask for reports weekly from the CMEs and the carriers to know how things are going. And then he's going to meet with them bi-weekly, at least for the next several months until an agreement is in place. That is his goal. And then as they've got an agreement in place and they're moving toward more of a network solution, he might let up on that just a little bit and meet monthly. But he will continue to meet with all of the parties until you all convene in the fall again, so we can give you a robust update as to where things are at. So I'll defer to Commissioner Henn if she wants to add to anything.
Yeah, no, thank you so much. DHHS has been proud to stand alongside the insurance department this session to try and make progress on this important issue. We have been agnostic about the mechanism by which this is paid for. What we know as DHHS is that we are seeing families with intense needs who, if they don't receive a program like this, will end up in psychiatric inpatient treatment, will end up in residential treatment. And we know that the evidence suggests that while that can be an important source of treatment for certain individuals, long-term, we improve outcomes, we save money when we can address it through the evidence-based criteria that Fast Forward follows. The only thing I would add, and I only saw Commissioner Betancourt's summary a few minutes ago, so if I had been given the chance to add one line, I would urge us to remember that this is not a new issue for us, and that going back to even 2020, 2021, there are numerous reports that came out of this legislature in which many of the same individuals, groups, carriers, agency officials gathered on this very issue. And the results have been to study and negotiate and see where we can get. So I think what I would urge, to Jennifer's point about if this moves to interim study, how do we get a different result? How do we ensure that the updates that are provided are substantive? How do we ensure that, as Commissioner Betancourt has offered, we are truly holding all the parties accountable to making progress? Because that is what I fear, is that I don't think Jennifer and I want to sit before you 5 years from now saying we continued to negotiate, we continued to study, and we've gotten nowhere. I think families deserve better. I think taxpayers deserve better. And so I would urge us to keep that long view as we recognize that while there's been progress, we don't yet have a guarantee, and that's the guarantee is what we need. So I'll just close with that.
Okay.
So instead of an interim study, would you guys be okay with the idea of like amending it so that there are carve-outs for people or for insurance companies that are working and doing what they need to do, creating case plans or whatever for covered people? Because I think part of the reason you guys had as much success in the last week is likely because the mood of the committee was pretty clear of what we thought about it. And I think that this might have got the ball moving, and maybe we shouldn't let off the gas and just say interim study. So I mean, that's kind of where my gut goes to is we can actually make it so that any good faith negotiations and acting insurance companies won't be impacted, right? We'll have a carve out for them.
Yeah, we have
And then when there's
momentum.
other issues, we could continue to study for why it's not working for other ones, and ultimately, if this passes, eventually there'll be a consequence so that the taxpayers aren't continuing to pay and subsidize insurance companies and ensure that people are getting the care.
I mean, we're always happy to discuss amendments. I know relative to the assessment, though, and I'm certainly not the attorney, so Michelle can speak to this component of it. The way that the assessment is drafted in the current bill that you have before there are some legal challenges with that. So I don't know that those are surmountable. Like if we can get past those, that the way that it's drafted would have some legal consequences to the way that the bill as drafted is trying to apply the assessment to the covered lives. So Michelle can maybe speak better to that than I can, but it would just be whether that could be worked out or not. I don't know. Again, I'm not an attorney to be able to speak to that, so.
Okay, thank you.
Okay, Representative Herbert, hang on just a second.
Sure.
Take care.
So just so I have it, there's tiers, correct? And it's the upper tier that is not getting financial support at this point in time. Is that the goal that you are looking at the most? In other words, once you get, I can't remember, was it 5 or what was the tier? I didn't know, but there were, we've run into the money wall, and the fact of the matter is, as in my particular point of view, is that we need to have the exact financial goal, so we'll know what we're what the problem is and can we address it. That's all. I just, because we're in New Hampshire, we're pretty frugal here, and there's always the issue of, are we financially doing the right thing? And quite frequently, in my opinion, we often aren't. So I would like to focus on that and see if there is some answers, maybe a lower price or something. I don't know what, but I want to know everybody, that's what we're after.
So I think the tiers you're referring to are a reference to what we sometimes call the continuum or the spectrum of our children's mental health system. So, and insurers cover many of those elements, but the one we're talking about when it comes to commercial insurance, I'll specify, which is generally called Tier 3. So, when a child has a mental health issue, obviously the best thing is to deal with that, to manage it in the least in the home, in a community-based setting, with a therapist, in the school if it's appropriate. Essentially, you want to engage in prevention because we know that ounce of prevention can be worth so very much when it comes to understanding the issue. For some youth, because of the nature of their condition or because of family circumstances, perhaps that family's gone through a very difficult time, a divorce, a loss of a loved one, something else, simply addressing that through typical counseling, go to the therapist once a week, kind of managing it with medications is not enough. And so then that is what the higher tiers exist for, is that when an issue is becoming more acute, these are the circumstances where families are saying, I'm not sure my child is safe. I'm not sure that I can have this sibling alongside his or her younger siblings. Those are the situations in which we need to take important action to avoid the problem and the suffering from becoming much worse, much more costly. These are the situations where we see youth sometimes ending up in the emergency department because the family or the support system doesn't know where else to turn. That is where this tier becomes essential, because what we're essentially trying to avoid is progression to even higher tiers, which are so very expensive. A single day at Hampstead Hospital for youth can easily be $1,500 a day. And that is not a one-day stay. That is oftentimes a at least 10-day stay or much longer. So essentially, and then when kids have to be sent to residential treatment programs away from the home, we can be talking $500,000 a year, $1 million a year, not unheard of. So what we're essentially trying to do with that tier 3 is use this evidence base that we know from not only the medical and clinical literature, but also from what the federal government has encouraged us to consider clinical best practice, the CMS, is a way to prevent that by wrapping supports around a family, bringing people together in a treatment team, doing what this very special program does. I think you're asking about the costs of the program because there was some confusion about that at a prior meeting. Our fiscal note characterizes it as $2.5 million. The reason is that is the portion for which the state is essentially providing general funds to care for the kids. That, like, if I have commercial insurance through my employer, but if my daughter needs fast forward, it's not covered by my commercial plan. So if my daughter needed that treatment, this would be an example where the state would be picking it up. In effect, it actually costs a little bit more to administer that program per child, and that we can talk to the providers, the CMEs, about that. But that's where there was conversation at the last meeting. Is it really worth a $6 million program? What I can tell you is that we're trying to be conservative because the state is providing $2.5 million per year toward those kids.
Representative
I
Spear,
just,
you.
just to add to that, Representative Herbert, so to your point relative to the cost and knowing what the cost is that we would be paying for it, that is why we're trying to encourage to get a single case agreement so that the CMEs can start billing insurance right away. So they will now immediately know what these costs are. And then once they get that snapshot into this case of this child and what their care looks like under the array of services that we want to keep intact, then they can use that to help build a better network contract to make sure that the full array of services are going to be incorporated into a network contract that will then encompass all of that. But the single case agreement is going to kind of give us a view into that. And and Anthem would kind of be the first out the gate, but then the commissioner would certainly be leaning into the other carriers as well to say, if you have any kids that are also in this program, you too, I'm expecting you to come into a single case agreement on your cases so that everybody is moving to, it's not just Anthem because they have the largest market share. All of the carriers are moving toward that goal of getting a single case agreement, seeing what the costs truly are, and then bringing these folks in network if possible.
I guess it was last year, we worked on the bill to square away ambulances. And the commissioner was very hard driving on that. Is he going to be any less hard driving? Because that worked out well. In 2 months, we had an agreement.
No, not at all.
I've seen him in action, so I know he can do it.
No, not at all. He's made that commitment to this group. He's made that commitment to the governor's office as well. She's been watching this legislation very closely and cares about this issue. I certainly don't want to speak for her, but we've made that commitment to everybody that this is really, he does not want us to see us slide back on this. It was, I think, a good reset for the group when we met on Friday, and that's the expectation he's set forth going forward.
Well, that's pretty good. The other comment I would like to make is that the original bill seemed to think, well, no, I guess what we have to remember is that insurance companies and how they work are not Medicaid. They don't work the same. Their risk levels are different. The payments are different. And how they impact their premium holders is different. Everything is different. So the idea that we're working on some kind of a way that we can fold this program, this very worthwhile program, into a way that insurance companies can look at it, I think is absolutely paramountly important. And so I'm glad that we're doing that, and hopefully it'll work out well.
Thank you.
Thank you. Thank you for taking my question. So anyone in the industry is fully aware that single case agreements are extremely hard to architect. Not only that, but they're one patient, one carrier. So kind of following on to what Representative Sullivan said, we have momentum now. We have codes that were provided. So why wouldn't we just keep moving and amend it so that there could be a runway for people to come into contract and actually make progress?
Yeah.
Yeah, I mean, I can't speak to the mechanism, but what I will say is where we need teeth here, where we need your help holding accountable through whatever approach is taken, is making sure that there is a service that is provided that is a full bundle of care. One of my concerns when we think about that translation into a commercial context is how when you take a service that is by its nature effective because it is a bundle and you start separating it into individual codes, I get very worried about what that means for families. Are they actually getting the quality product that they need, or is it being broken into the traditional fee-for-service piecemeal approach? And so I think that's something we all need to be listening for and demanding, regardless of mechanism, is that it's held together, as Commissioner Betancourt likes to say, as a full packet of sticks. And I do think from a payment standpoint, while I'm no expert, something that's capitated, something that's holistic in nature, which certainly the assessment is, but perhaps there's a way to do that also in a more market-based approach, that is going to lend itself to keeping that bundle as opposed to breaking it into component parts, which are not what this model is about.
Hang on, all right. She's next, and then you're
Thank
next.
you. Thank you for explaining it again. So I'm looking at the chart, and obviously Medicaid does not work like commercial insurance, but we're trying to figure out how we could cover services. And it seems that we are very close to doing that. And I think that as we work toward this, we'll figure out the codes. So the action item was to get the billing codes. We have many, many, many billing codes, so I don't want to use that as an excuse anymore. However, if we look at this chart, 30%, this is the commercial market. The insurance companies should be paying for this. The state should not be paying for this. So I want to get to something as soon as possible to make sure that this area, this 20% commercial requirement is rectified as soon as possible. So I'm not sure how we have to do that, what we need to put in a bill, what we need
That's
to
part of the interim
mandate.
study.
Well, but I want to make sure that if we have an interim study, we have very distinct deadlines, so the next time we come back, this has been resolved.
But if there's an interim study, there's no incentive on the insurance companies. You
Well,
know, I
that's what
think-
I'm trying to figure
Yeah,
out.
and that's
Is
what I'm
there-
getting at. That's what I'm saying. I like the idea of an amendment that could do a carve out for the insurance companies that are doing what we want them to do, which you just laid out well. And I think the reason we see any progress is that I really do believe that it was last week when many of us said, hey, this is messed up and like, let's pass this.
Yeah, I
And that sort of
agree.
woke
I'm
people
just
up.
not sure how to craft that so we could say, do this or else.
Well, yeah, well, I think you have the bill right here, and then you have an amendment for companies that have done what you want them to do, and the ones that haven't will then have to deal with this bill. That's what I think is the best solution here.
I have a question for
Okay.
Commissioner Hen.
Please.
Are you aware of any similar programs in other states, such as, we have it Fast Forward here? I would imagine there's similar programs in other states.
Yes, this wraparound is considered best practice. That's why the Centers for Medicare and Medicaid Services put out bulletins urging that this be covered because of the clinical evidence behind it. So yes, it is widely delivered. So yes.
So I would
But is it
imagine,
delivered through Medicaid
I
or
would
is it delivered through
imagine,
the insurance companies?
I think I'm still on here.
I'm so
still
sorry.
on deck. Thank you. So I would imagine that in these other states where there's commercial carriers, they've figured it out and there's coding for that bundling. We all know bundling works, right? Bundling saves money.
I don't know the answer to that. I mean, I think we need, one of the things we have done in the process this year, which has been progress, is the New Hampshire Charitable Foundation brought on technical experts, consultants to look at these very complex claims databases nationally to understand that. Is it that it's being covered, but in this piecemeal way? Is it being covered as a bundle? But no, we don't seem to have a clear model that we can say, let's do what X state is doing.
My question, I guess, is answered by that. If you've seen any models that actually use the insurance companies to pay for it as opposed to Medicaid?
No, I think the state of New Jersey may have an approach where they essentially charge commercial insurers kind of retrospectively for their members, but I don't think there's actually a way in billing that it's been done like prospectively.
So we could be the first.
Perhaps.
Okay, thank you all. The chairman has returned. No worse for wear, and I think our conversations right now will be terminated, and we will go to the chair. Thank you all.
You want us to stay for 498?
Any more questions? Okay, so you all got the email last night?
Yes.
Okay. And that the issue is that, that we have a model in which we can get this problem fixed. Because what we heard in the public hearings prior to it was all about, the billing, and they didn't have the codes. And now we have codes, and we have billing, and we have a department that is totally committed to getting this problem solved. So I think the right answer for this bill is to interim study it at this point. And so that comes September.
Yeah, but we want to make sure that we continue to make, I'm not sure when these two started talking to each other.
Okay, so,
But to have this issue go on for like several years
right.
is ridiculous.
I think we should do an
want to
amendment.
Make sure that the taxpayers aren't on
I think
the
we
hook
should.
for this, and that there's an actual resolution by the time we're ready. So I don't know, how do you craft that in the interim study? Like, you will have a solution by whatever.
Well, no, basically I threatened the solution. I said that come September, if this thing continues to be a problem, then we will have to try to force the issue. But my personal opinion, as the person who created this assessment system that everybody seems to like, okay, this is an abuse of that system. It should never have been used. You should never be used for this type of thing. It would be an incredible can of worms, because then it would open the doors for using this assessment for anything and everything, and it's just inappropriate. The issue here, what occurred, was when we now discovered that the Executive Council had approved that they could bill in private insurance. But at that point in time, for some reason, they were beating the wall, they couldn't get it, or it just didn't happen. Okay, so when you look at who was in the room, who made this decision that private company patients of private companies are going to be involved, okay, was on the understanding that yes, private insurance would be billed. All right, and so therefore our mission for this committee is to make that happen. Okay, but that in terms of where we get to this point at this moment, where all of a sudden it said, oh, but yeah, we got this nifty little model out here where we can do this billing. No, this nifty little model is designed it was very restrictive. It was designed specifically to help out the individual insurance market originally. Okay, it turned out that when it came to vaccines, everybody, all the parties agreed that the state could buy the vaccines cheaper than insurance companies can get the contract. So in that sense, it was okay to use the assessment again. The third time it got used was for Medicaid expansion. And that went to a committee of an oversight committee. I was on it, and I voted against it because I didn't think it was appropriate, but it did pass. No, I didn't try to repeal it because it is right now, it is our state funding mechanism for the Medicaid expansion. Okay, so leave a sleeping dog lie. Having said that, to take this program, which is managed by Health and Human Services, directing it to, they're contracting with NFI, just like if NFI wants to provide this service to private insurance, they need a contract. And that's really the heart of the issue. How do we mandate that to say they have to have a contract? Okay, theoretically we shouldn't have to do that. And so that's why I'm interim studying it. Is just that I have a commitment from both sides of the issue that they will absolutely get this work done, and the department is going to meet twice a week to make sure this is done.
So what's the harm with an amendment?
to say,
An amendment saying that any company that does is exempt from this, but the ones that don't. So right now you have a single case agreement with one company, but that doesn't cover all of them. I
No,
understand that you have a lot of.
I have to admit that when the conversation I had with the insurance department, I wanted that they do not just one case study. I wanted each private insurance company to have a case study.
What's the incentive to not just walk away?
No, that's the point. Well, let me say the
That is
incentive
the
to,
point.
to walk away. The incentive to walk away is then that we would then be resigned to have to
Then we have to do
apply
something.
this.
So why can't we just do this, have the amendment for those who are compliant with
I mean,
what we
at
want
this
them to
point,
do?
that's not
Well-
not appropriate way to do it. To say is if you don't do it, then this is happening.
don't- so
They
here's-
know what the threat is. Insurance
Here's my,
companies know
here's
the
my
threat.
question. Why, okay, you can tell me why it's inappropriate to have a carve out for those that are compliant with what we want, and then the ones that aren't would then be impacted by this.
The big problem, fundamental problem is we actually don't know who these kids are. The private insurance company, the private insurance companies have all claimed that they have not been given, told how many kids that they cover are in the plan. That hasn't happened. So at this point, I understand that you want to pass something, but in this case,
Well, I mean,
what
we
we've
should
done
stop
is what-
subsidizing, we should stop using taxpayer dollars to subsidize insurance companies.
I would have to say, frankly, much as when I looked at the executive council making the decision that they would include the private income, I would have to say is that I think what everyone's logic was in the room at that time in the executive council meeting was that at the end of the day, we don't know how many private insurance kids were going to be available, but that this is a benefit that is outside of the normal Medicaid benefit, because this is a unique program. Unique. Okay? This is very unique. Okay? There are not a lot of states that do this.
There are many states that do this. They
Yeah.
just
Okay.
testified to that.
All I'm saying
Yes,
is
she did.
that this program, okay, that we the state, what we heard was, oh, well, there's 500 kids and there are only 50 of them, so that 10% is private insurance. If the executive council were looking at it and say, we should make this a program available for all kids. All kids. They could have said at the time, but if the private insurance companies don't negotiate or don't private or you don't bill them, it's not going to be available. No, because they in good faith assumed that these NFI would bill insurance companies. So I'm not moving any farther than that is the expectation and we want to fulfill that expectation. As you know, in terms of the way I like to do business is that we want to negotiate a compromise and then make it happen. And this is not the first time I would say take a complicated bill and say let's interim study it because we want to see if the parties do negotiate. If they don't, if we get to September and find out this whole thing is blown up and that this won't happen, then absolutely I would sponsor some legislation to solve the problem. But I wouldn't use this mechanism to do it. The mechanism I would do it is say that insurance companies have to pay.
They've been literally working on this for about 5 or 6 years.
No, they
now.
haven't. That's the whole point. They have not. They
We've
have
heard
not.
that from.
I'm just telling you, after doing my research on this thing has just been sitting there, and that basically, I'm not going to throw anybody under the bus, but I'll tell you off record who I think is for fault for why this problem hasn't been solved. I'm not going to say it publicly, but I do know who's at fault, and I'm not going to make a big deal out of it. I'm just going to say our job should be to be able to get this thing done and get it fixed. Okay, so. In terms, now let's talk about amendments, all right, just so everybody understands here, all right? We have to have all bills out of committee next week, okay? Unfortunately, will be out of town on Tuesday. I thought we were going to get everything done today and tomorrow. I originally, that was what my plan, because waiting till Wednesday, we now have the speaker, the House clerk all over us, like, all over me like a wet rag, in terms of not getting reports in, getting things done. I do know that we do have one bill, which is the bill I sponsored, the bill that I sponsored, the RISC bill, which is over on the Senate. The senator over there is asking that we would pass his bill unamended. Okay? I was going to wait till the last day before I did that. And that is, so that's why we will be coming back on Wednesday morning to at least take care of that. Yeah, next week. Okay? The risk pool. Okay? So that is Wednesday morning next week. But, you know, theoretically, the bills aren't due till Thursday, but, the clerk does not tolerate that. And so therefore, I would really like not to have too many things left over this weekend. Okay? So yes, I'm sorry that I had to go to the doctor, and I'm sorry my car died, and I'm sorry I'm here, but we do have all afternoon. Right? So I'm just saying for this particular bill, that given that the progress that we have made with the involvement of the governor's office, all the parties, they were in the room, and you got that letter from the insurance department. I truly believe that we're going to get this problem solved without legislation. Okay? All right.
Representative Miles has a question.
Okay. Yes, Representative Miles.
I'm just concerned about interim study versus an amendment with a run-in opportunity because if we look back at the prior, I think it was prior authorization legislation something for 2024, there's still no rules done by the DOI. So I'm concerned about ongoing delay tactics to get things on the books.
I don't believe there's any incentive for the insurance department, to delay it. If there's any delay, as we know on almost anything, it's the contractual arrangements between the two parties. It's usually that the insurance company wants to pay pay less than what the provider wants to be paid.
It's been testified that it's best practice, and I think the committee should always support best practice for patients. That's all.
Okay. So in terms of, like I say, if you want to start doing amendments, okay, amendments is going to be a problem because we need to make that amendment today so that we can exec the bill tomorrow. Okay? And I don't, if you got some wonderful language that you think that it's going to solve this problem, we can certainly, put it together, but then we're going to have to all stick around and wait and see and read that amendment and see if it really is going to do what we want it to do. I'm just saying I don't think we need to do it on this particular bill. Okay?
Where's the money?
Where's the money?
Where's the money?
The money is,
I think we can, I think it's worth, why don't we, I could spend the afternoon looking at that.
okay,
and see what I come
fine.
up
All right.
and see if I can come up with
So
something that's-
we'll recess this discussion on this bill until this afternoon.
Okay.
Okay. So which ones did you guys get done?
498.
We didn't do any of these.
We just went through the amendments, that's all, by number.
Okay. Okay. All right. Well, let's start at the top. Okay. Senate Bill 524, establishing an on-premise license to deliver. Okay. This is the bill. This is the bill that we have now. A bunch of other things added to it. 524.
Yeah.
Okay.
24.
Did you guys have this conversation?
No. No, there wasn't any amendment to it.
He only discussed one.
Okay. The amendment 524 got distributed before, right?
Yeah.
It's already been distributed.
As amended.
We did not discuss it.
No, it's
Okay.
524 as amended already.
Okay. No new one for today, right? So it's the same amendment that's always been out there. And,
I will move it.
okay. Okay, so does anybody have a problem with that amendment? Somehow I remember somebody having a problem, but I'm not going to worry about it now. We'll take it up in committee of conference. Okay. Okay, Representative Petusek.
So what do we?
Okay, that is going to be to pass on the amendment.
What is the,
Amendment number
79.
I'm
1579.
1579. So I have a lot of notes on one. Okay, so we're on 1579
Yep.
and we're gonna, oh yeah, so I think I'm just trying to get back to where we were last week. So the concern was we could, oh, okay, I remember the concern. This is, everybody's saying this is gonna be a ton of burden for the smaller businesses in the
Right,
state
the
versus
vaping
just in
shops.
more enforced auditing would be the alternative.
Right. So the upshot is if they don't, if they think that us asking them to track where they're buying, who the wholesaler they're dealing with, and how much they sell, if they think that that's too much of a hassle, then I would say is stop selling it.
And so, if they were selling illegally, who's enforcing that?
So that was the
Shut
problem.
'em down.
That was the reason why we passed the legislation in the first place.
Mm.
Because what was happening was that that unlike cigarettes, vaping devices they come in many forms, and there's 100.
Right, we can't put the
manufacturers.
stamps on.
And can't put the stamps on them. They don't know how to regulate. They come in and as the chief said, they're coming in through the back door and they're getting sold, and we don't assess the tax at the retail level.
Right.
We
no,
assess
remember
the
that.
tax at the wholesale level. And so therefore, that we need to make sure that retailers are actually buying it.
So
from a
my
licensed
question is, who's gonna enforce it? Like, is the liquor
Liquor
commission gonna
commission.
just randomly shop into a random
No,
store?
Liquor
if they're
Commission
selling it,
will
or-
be looking at these reports monthly, now they
No, but I'm
quarterly,
saying,
now
let's say
quarterly
they,
reports.
so if the little convenience store in whatever town is still selling them illegally, somebody just has to whistle blow.
John Hunt's rule of licensure will shut them down.
And the whistle, somebody will have to blow the whistle, like, because they're not gonna be audited if they presumably
Well, I'm
weren't.
saying that's why we need the audit. The audit is so that we don't have to wait till, that somebody informs us that they're buying it illegally. We'll be able to sniff it out with these reports.
Well, we wouldn't if somebody was continuing just to buy illegally. We'd have to have like some sort of census of who's selling these things right now.
The Liquor Commission is pretty much in these facilities already because they're enforcing the tobacco tax.
Okay.
And so therefore, yes, if they suddenly saw vaping devices in there and they're filing 0 vaping reports, then yes, their
Okay.
license would get suspended. There's 2 amendments? I thought we merged them oh, I see, right. So whichever one, yeah, what was the one we have is 1579. 9.
9.
Does that have a later date on it?
That's the only one I got.
Well, I don't know. Is that the correct one? Where's my liquor enforcement? Are they here? There they are. 1579 is the correct one? There it is.
1492 is the old.
That's nice you guys moved over to that corner now. Not behind the column.
1492 is the old one.
And then there's
Okay.
1582.
So 15,
1582 is the 1582.
what was 1582?
Yeah, that's the latest.
I don't have 1582. No.
What the heck is this? Oh, this is, so I believe this amendment was put on the 1579, right?
Yeah.
Okay, so if you look in 1579, you should see this language. Because this is the teachers. Right.
April
And
20th.
this is the teachers. So where is the teachers in 1579? Okay,
1579 is 28.
this is what she says here.
Yeah, I know.
Okay, so this one shows,
1582. Not in my notes.
which section of the bill are you saying? Section 6?
79. I
Page
remember 1582.
Page 4. This 1574 does not have that. Oh, this is 1492. You trying to goof me up?
Wait a minute. 1579?
1579 is 20.
I
Okay.
gave you this and you.
Somehow yeah.
28.
Okay. So 1579
1579 is the one. That's the one.
Okay, line eight.
has the same
She says
language.
that this
Yes.
is the one.
Yes. Okay. Yes, I had the wrong one in front of me. Okay.
All right. So we're doing 1570.
1579.
That's what I had.
Okay. All right, so Representative Pasusek, seconded by Representative Burrows, moves ought to pass on the amendment to 524. Actually, this is a subcommittee.
Yeah.
Do you have your subcommittee list?
Of course. It's out in your pile of stuff.
Okay. So liquor is Patusek, Walsh, Post, Hunt, Burrows, Sullivan, and Spear. Okay, are we ready to vote? All right, all those in favor say aye. 1, 2, 3, 4, 5, 6, 7. Okay, 7 to zip. Okay, and all those in favor of ought to pass as amended? 8, 4, 5, 6, 7. Okay,
7-0.
perfect. All right. Next one. Senate Bill 444, animal testing with other comparable methods are available. So that amendment's been passed out?
It's in the
Okay,
pile. Here,
okay.
got them by number.
All right. So what was the feeling of the committee?
Yeah, we had to
Okay,
talk about it.
We had a
Nobody raised any
quick
questions.
question. So it was amended to have the reporting.
correct.
So there was a question if there was, so there's no bans in here, it's just the data collection.
Correct.
So was there other conversations, Chairman, that you had that you might want to
Yes,
help
the
us with?
governor told me that they would veto it in this current form because they feel it's anti-business for biotech. And they want to entice biotech states, companies into the state. And that if they knew that we had a regulation that no other state had, that would make us, that would be a disincentive to come to New Hampshire.
But just for the reporting, do they
Just,
understand?
and
it's
he
just the
absolutely
reporting?
understands that this was going to be, this is purely disclosure, and it was going to be kept confidential. They understand all that, but that at the end of the day, they said if you want to amend the bill so only for cosmetics.
For the reporting?
Yes, for this, find out if there's any cosmetic going on. But
But
that
you didn't get one, right, though? You didn't get the amendment done?
I have not done any amendments. No.
I didn't think so. So should we just pass this and let her veto it, or what are we gonna do?
But how do people feel?
I'm fine with passing it as is. I mean, we don't have to do her bidding. I mean, if we think that this is reasonable, I know everybody on this committee does, because we talked about it. Then I'm fine passing it. I don't think anybody here nobody's raised any concerns about this language or this idea of just simply aggregating in an anonymous way the data.
Yeah, the data is, will be aggregated.
Right.
And it's anonymous.
She's going to veto it because unless we amend it to be only cosmetics.
Theoretically, we should be a co-equal branch. Theoretically.
So you agree with her?
What is your recommendation?
I would have to say that given that we've been down this path with the governor already when it came to paint, then I probably, if she's going to veto it on anti-business versus it's a tax, then I guess I would be certainly persuaded that would be the right answer. What would be the right answer? To limit it to just cosmetics.
But we don't have the amendment.
Remember, we're going to be here this afternoon. So,
I think we should pass something. If you want to do that, I'm fine with that. If not, we can just pass this and let her veto it.
okay,
I don't care about the veto. I mean, if she vetoes it, that's on her to explain her thinking.
right, right. But I just hate that her, I don't know, because it then implies that this committee is anti-business.
Not
Because they're
necessarily.
vetoing it on the anti-business, that implies we're,
I mean, that's,
Business.
I don't think that implies like you're pro-tax. We know that that's not
but
true.
you said you would live with it, so let's,
No, I would. If you want to make the amendment, that's fine. But
Okay.
I'm saying if we don't have time to do that,
well, we can. We can actually, this is, like you say, just because you want to have time to take up 490 and 498 and come up with some kind of amendment, I'm not sure what it's going to be, but at any rate, so,
so you're doing this amendment, not me, to be clear.
at this point, I'm doing it.
Okay,
Yes,
good.
you've done your job. Okay, so,
So we're
You-
just
okay, let me just-
amending Page 1, line 14, to say testing facility means cosmetic,
that research, studies, tests, or experiments involving animals within the state for cosmetic purposes, Kurt? Since I'm mucking up your bill, and you, at one point in time, wasn't this original bill way back when, was just cosmetics? Right. So I'm asking, if we were to do cosmetics, where would we be putting it in the definition? Right? Or should we put it, normally you're not supposed to put law in the definitions, but I would say it'd probably be down in Roman numeral 1. Using animals,
Yeah, but then look at line 23. It says every testing facility operating within the state shall submit the report.
right, every testing testing facility for cosmetics.
Yeah, so that's line
How are you going to define cosmetics?
14 then.
Need a definition for.
Did you have definition in your old bill, Kurt? Okay. Yes, sir. Yes, yeah. Well, you could just sit over here, and, any microphone. Yeah, any microphone's fine. Yeah. Just use a mic. Yep.
Thank you, Mr. Chairman, and the members of the committee for the indulgence. For the record, David Cuzzy with Prospect Hill Strategies, representing this afternoon, New Hampshire Life Sciences. Andrea Hechavarria, it being school vacation week, is on vacation. So very quickly, if I may, because we didn't have a chance to talk to Representative Sullivan's amendment prior to when you got here. So we would be respectfully opposed to the amendment as written. We would suggest, I guess, we'd be, if this were to truly be pertinent only to cosmetics,
Correct.
New Hampshire Life Sciences would be neutral on that.
Right.
However, respectfully, I do think that the two changes, the first, I think we need to make sure that on Representative Sullivan's amendment, I'm looking at 1676H.
Correct. That's where we're
Line
working on.
13,
Okay.
the definition of animal, New Hampshire Life Sciences would respectfully suggest that needs to be aligned with the definition of animal under the Federal Animal Welfare Act.
What's that? That's kind of long and convoluted, and I probably won't be able to understand it.
No,
anyway.
well, again, I believe that excludes rats and mice, which you may remember from last week was a point of discussion. So that definition would be important. That's the definition that I believe California, Maryland,
So
some
the
other states,
California, I mean, the U.S. federal law excludes.
they do not, mice is not defined as any living vertebrate.
Okay, so what is the definition? Why don't you read me the federal
So
definition?
I don't have that right in front of me. I apologize.
Does anybody have the federal definition in front of them?
And we would be happy to provide language that would define a cosmetic testing, that would define cosmetic testing or cosmetics for the purposes of this. We'd be happy to provide something, the definition for animal, and then the cosmetic testing facility. I'd also point out, I'm certainly.
Cosmetic testing facility, right?
Yes.
Okay.
I'd also point out, although I'm certainly not speaking for any of the universities, but I would I do think that, I'm not sure how they would fall under this, even under the changes that New Hampshire Life Sciences is suggesting. So that might be something worth looking into. I know New Hampshire Life Sciences want to make sure that they're not unnecessarily caught up in this.
Well, you're taking the university out, but the whole intent was that we didn't want to we wanted to really know exactly what testing was going on.
Understood. So I'm just providing the feedback from New Hampshire Life Sciences that if those two changes were made, the definition of animal and we can suggest, we could provide that, and cosmetic testing, we could provide that as well, then we'd be neutral on that.
Okay, how do people feel? What's that?
We'd support that, obviously.
Obviously.
Yeah. Exactly.
Okay.
Higher institutions.
All right, Representative Purcelli. Purcelli, second by Representative Miles, moves. Actually, who's on the committee? Yeah, excuse me. No, never mind.
Business.
Never mind. Okay, who would like?
Well, this is business.
No, this one's business.
Yeah.
Yes. Okay. So, okay. You're not on this one, right?
No, not on it either.
This
Okay.
is business.
So, business is Ammon, Pressa, Batusek, Hunt, Thaxton, McAleer, Herbert, Spear, and Salvi. So, for interim study? No, you want to pass it? Okay, no, we were going to take up a motion because we realized that if we were going to make this palatable for the governor, we would have to amend the bill.
Interim study, get it done, and get the bill out.
I'm too lazy for that. Okay.
You're all right with the interim study now?
You've been here 40 years. I'm all in.
All right. Okay, all right. Who would like to make the motion of interim study? Okay, Representative Herbert. Representative Herbert. Seconded by Representative Patusek.
Yep.
Moves interim study. Any discussion on that motion? Okay, so I'm looking at that Ammon and Salvi are not here, so they'll balance each other's out. So that means Pressa, Patusek, Hunt, Thaxton, McAleer is also out.
He's not here. So
Okay.
Burrows can vote for him.
And then Herbert, Spear, and Salvi. And okay, so we're saying Sam. Okay, so you'll vote for. Okay, all those in favor of interim study, raise their hand. 1, 2, 3, 4, 5, 6, 7. Okay, interim study carries 7-0. Okay, so we want to discuss the mental health one this afternoon.
We beat it to death pretty good this morning.
What? Okay, so you think we're ready to take action? Ready for interim study? I'm just listening to. Okay, he's going to do an amendment, and then we can move to interim study. Okay, next up, relative to insurance coverage for services provided by natural path providers. All right, so this is insurance. Who?
You missed
This is
544.
544.
Okay, yeah, relative to managed care laws.
And there was an amendment to change the date.
Effective date, okay? Who would like to carry this bill forward? Representative Spear? Yes, you did. Okay, yeah, are you on this? Yeah, you're on this in committee. Yep, Spear. Okay. Representative Spear, seconded by myself. Moves ought to pass on the amendment number.
1703.
Oh, yes, yes. Oh, so.
1703,
Yeah.
changing the effective date. Okay.
Right here. January, is it? July 1st.
No, it's changed to January.
She got the new one, right? In January.
That's right. This is the wrong date.
Yeah, I know, but there's a new one.
That's why
But
we're
you
not,
have in
but
your-
we're taking
it's in your
1703.
stack.
Okay.
Because you took my stack.
Okay.
It's January.
Okay. All right. The motion is made and seconded. Any discussion on the motion? All those in favor, please say aye. This is insurance now. Okay. Herbert's on. Herbert's on. Buchuzek is not on this one. Okay.
That's what I'm saying.
No, insurance.
Oh, insurance. I'm not on
Okay,
insurance.
right. Spear. Okay, 1, 2, 3, 4, 5. Representative Miles? You're, okay, those voting no on the amendment.
Can I ask a question? The original intent of the bill was that there would be no formulary changes mid-year, correct? And the amendment just makes it so that they give 60 days notice instead of 45 at any time in the plan year?
The amendment I'm looking at here is just you change the effective date.
Yeah.
Right, but the overall bill is so that they don't, so that they can still do mid-year plan changes, which I am opposed to, so.
Gotcha. Okay, so the vote is
5-1.
5-1. Right, because Purcelli, Hunt, Thaxton, Herbert, and Spear, 5-1. Okay.
OTPA.
Okay. Okay. Now, ought to pass with amendment. All those in favor? 1, 2, 3, 4, 5. And those opposed? 5-1. Okay. All right. Moving on to natural paths. Who would like to make this motion of ought to pass?
I move ITL.
What bill number?
Okay.
606.
All right. I will make the motion of ought to pass.
John, is this 606?
This is 550.
550, okay.
No, amendment is the effective date. Yes.
Effective date.
Okay.
Amendment
Right there.
1702H.
Yes, please. Okay. And this is, yes, he's on insurance. It's insurance.
What's the number of the amendment?
1702.
02. Since we're like the last committee doing things, these numbers are in next to each other. Okay. So all those in favor of the amendment, say aye. 1, 2, 3, 4, 5, 6. Those opposed? Okay. All right. I don't know. Let's see, who did, yeah, yeah. Who,
Put up your hand.
okay. Okay,
clerk.
all right, for the clerk. 1, okay, this is insurance. Saxon's on insurance. Spear is on insurance. Oh, I don't see you
Yeah, no, you're not.
unless you're sitting in for Shariza.
I thought it was, is Mackler on that?
This is insurance, yeah,
Then I'll do Sharice.
right,
Oh,
okay?
okay.
And, all right, so that's why we have 7-1. Okay,
6-1.
6-1, excuse me, 7 votes, 6-1. Okay. Okay, then all those in favor of ought to pass with the amendment, raise your hand. 1, 2, 3, 4, 5, 6. Those opposed? Okay.
May I speak to it for 1 second? Briefly.
You can speak to the whole committee, but I think you
Okay.
said in the hearing, you believe they're not doctors. And they
It's it's an insurance mandate, and they have not gone to medical school, they have not gone to NP school, and they have not gone to PA school, correct?
Right. Okay. All right. Next is relative to insurance covers for biomarker testing. Okay. So this is insurance. So Representative Spear. Okay. And I'll second it. Is there any discussion on the motion of interim study? Okay. All those in favor? 1, 2, 3, 4, 5, 6, 7. Okay. All right. Next up, 614, establishing multiple caregiver self-insurance risk coverages arrangement for nonprofit. Oh yeah, we want to pass this. And okay. All right. So who would like to make the motion? Did we have an effective date on this one?
14 is in your stat. I number.
614.
The effective date is July 1st, 2027.
Yeah, no amendment, right? No, I didn't think so.
I can
Okay.
move OTP on that one.
Okay, Representative Miles. Oh, it moved it to July 1. That's what screwed it. It's going the other way. All right. Okay, 1626. That's right, gives it plenty of time to get the rules made, get this organized. Okay. So this is Representative Miles, seconded by myself. Okay, all those in favor of the amendment, please say aye. 1, 2, 3, 4, 5, 6, 7. Representative Miles, second by Representative Hunt. Moves ought to pass as amended. Any discussion on the motion? Seeing none, all those in favor say aye. 1, 2, 3, 4, 5, 6, 7, zip. Okay. All right. 573. I will move the amendment. And the amendment number is 1675, is that correct? Okay. 1675. No, this is not a cleanup. This is the amendment. The amendment is a cleanup of the previous amendment but yeah. And I did get a call from Justin. He's not here, but he said if ever there was a perfect bill, this was it. Where's the dog? I didn't let the dogs out. So, okay. This is business. This was business. Okay. So that's Pressa, Petusek, Hunt, Thaxton, Burrows, Herbert, and Spear. Okay. All those in favor of the amendments? 1, 2, 3, 4, 5, 6, 7. Okay.
And who seconded it?
Second.
Petusek. And now the motion is ought to pass as amended. All those in favor say aye. 1, 2, 3, 4, 5, 6, 7, zip.
7 zip.
Okay. And last but not least, 665. And it sounded like you guys did interim study when I was watching on YouTube. Did you
Well-
say something about not being ready for
We
prime
moved
time?
ITL because it wasn't ready for prime time in a variety of ways.
Oh, ITL, okay. She just said ITL.
Yeah, we said it wasn't ready for prime time. And there's language that's just, it does not meet the intent of the bill. And the gentleman from Nashua testified. I mean, This is nowhere near what the bill was intended to do and does nothing for improving transparency for consumers. So I do not think this bill is. No, was not my understanding. That's just the signage.
What do you guys, how do you guys feel? Interim
study.
ITL, you're right with ITL? Okay, Representative Miles. Second by Representative Burrows, move in expedient to legislate on Senate Bill 665. Any discussion on the motion? Seeing none. Those in favor, raise your hand. 1, 2, 3, 4, 5, 6, 7. Okay, so the only thing we have left is to talk about some amendment that Representative Sullivan is going to make during the lunch break. How much time do you need? What time? We usually give an hour. Well, it's driving over to Tandy's is a little longer than I expect. Okay, so we'll all be back at 2:00. We only have one bill left.
This is it.
Right, and I to me the pending motion should be interim study, but that should we. Okay, let's do it. So okay, so 498
So are you telling me that my amendment is?
might not be necessary. We're about to take a vote to find
Oh,
out.
that was great. I thought I mean, that's doesn't feel right, does it?
I'm just taking suggestions. Some people want to go home. They don't want to wait around.
I'm going to vote to interim study it, whether I vote on it now or an hour and a half from now.
Okay. And you're not even on this subcommittee. You can, that gives you more time to make an amendment up for when we exec it. I think we all take our job very seriously.
Well, this is why it needs to be interim study. These are our choices. And so if you want to do it right, slamming it together with something this afternoon is not going to be.
It's not going to do it right.
Right.
Okay.
Get it done right.
Okay.
Yeah.
Uh,
Instead of half-assed.
Okay, Representative Porcelli. Seconded by Representative Spear, moves interim study. So this is Porcelli, Miles, Hunt, Thaxton, Burrows, considered for Sharissa, Herbert, and Spear. Okay, all those in favor of interim study, raise your hand. 1, 2, 3, 4, 5, 6.
7.
And Representative Miles, are you? Okay. Okay. 7-0. Okay.
Done.
Then we're done for today.